one thing I've heard a lot about, so I want to ask the group here and get everyone's collective knowledge. I think one of the questions that we were still left with as the field was moving forward while these trials were being conducted was that we got approval of adjuvant pembrolizumab. And while TiNivo-2 allowed for adjuvant pembrolizumab to be the IO that someone had progressed on, I think only about 16 patients were enrolled. So I don't really think we got enough patients in TiNivo-2 to really inform us. And I wonder, though, if still CONTACT-03 and TiNivo-2, if they, I guess, influence how you're treating patients that you're treating with adjuvant pembro, and then patients are perhaps progressing, on therapy or after.
Yeah, I can say a few things on this. So I mean, I'm a little bit more the pessimist when it comes to re-challenging PD-1 after PD-1. Yes, you get 1 year of treatment, but the truth is you actually have 1.5 always, simply because the receptor occupancy is so long. So you actually have a really long exposure to PD-1. And if you don't eradicate the disease during the time frame, I don't think a re-challenge will do it. I do think it's important to then think about other immunotherapy targets. Often patients come out of that space with minimal disease burden. They're being watched very carefully and closely. And, there is room for example, PD-1 CTLA-4. It's a low number, but it's a persistent number across different trials. Or there is space for development, quite frankly, for curative approaches or potentially curative approaches. The TKIs, HIF2s, in my book, they're all purely palliative. So it's important to have selection criteria there, or also options that may be more tolerable than others. That's the value, I think, of tivozanib, for example. But, coming out of that, we shouldn't always equate, immunotherapy after immunotherapy. We should say what it was. So PD-1 after PD-1 or PD-L1 makes just no sense. I mean, it needs to be a different target. And I would encourage the industry to develop more effective immunotherapies in that space, quite frankly.
Yeah, I agree. The one thing, if you don't mind, Katie, to add, the one thing that could be different is the combination of nivolumab and ipilimumab. There has been a study, a phase 2 by the name Fraction RCC, that showed that the combination of nivolumab, and ipilimumab post progression on prior PD-1 and PD-L1 inhibitor, the Nivo-3, Ipi-1, the Hammers regimen, provide around 17% response rate that are durable, around 40 patients. And now, is this related to the combo? This is probably Ipi only, etc. So in patients that have maybe sarcomatoid histology, so it would be hard to feel that you experience progression on pembro, or where the progression has been slow. I have used that, and I have patients I have cured. However, I went back to my database, and these have been patients treated with PD-L1 inhibitor mostly. But this is something I could do occasionally.
And Kathy, I just want to emphasize, Hen's point, which I think is truly important. And by the way, Tony put a really elegant algorithm of how to approach these patients on ASCO Daily News. So shout out there. I just want to highlight Hen's point about how do you get to metastatic disease post-adjuvant therapy is actually you can get it in different ways. You have different presentations. And we all talk about local therapy. I think we're going to learn a lot more what that means over time as more and more patients are being exposed to adjuvant pembro, and when we start getting more recurrences. I do have now almost a handful of patients who recur in one site or 1 or 2 sites, or we really think about resections, right? Also the staging. I mean, 2 of my patients were found with disease outside chest, abdomen, and pelvis, including soft tissue in the limbs, or shoulder, if you will. So I would just say that, it is an opportunity for us to understand about, and by the way, on the keynote 564, we actually see that, right? Well, we see less than 50% getting subsequent therapy, but also when you look at the number of local therapies offered, radiation, surgery, 25%, I really think it does speak to the different biology. Like there are different ways for patients who get with to progressive disease into metastatic disease, and they're not the same, and probably they definitely don't need the same approach. So I just think as time goes by, as we're going to have more and more patients, I think we're going to see in the future different data sets for kind of maybe the patient type that falls into these different categories, people who might get a dual IO-based approach, recurrence too late, perhaps disseminated disease, versus those who are going to have oligo recurrence, who might be offering a lot more local therapy, and we see what they do over time, because we actually don't have much data in that context. So I think just to highlight that point one more time, because it's not a one-size-fits-all, and we will see this over time, I believe, as more data sets are filled into more patients getting there.
Yeah. And I think maybe the one thing we haven't reviewed from the TiNivo-2 study, maybe to circle back, is the and I know Dr. Hammers mentioned this a little bit, regarding kind of side effect profile. We saw in CONTACT-03 a little bit of increased toxicity, in that combination arm, increased SAEs, I believe. It seemed, to my review, that the TiNivo-2 had pretty similar side effect profile as what was seen prior on TiVo-3, with that full dose, and then in the combination arm here, that there weren't, of course, now the TiVo being, reduced dose, but the combination there being having pretty similar side effects. So I guess, one question to the group here is, knowing it's a selective VEGF and that you certainly are going to be needing to deal with, hypertension, did anybody have any concerns about the side effect profile from TiNivo-2, or is that something that would be the point that you would, highlight to a patient when you're choosing your kind of next TKI?
Yeah, I have very much the same interpretation as you do, Katie, regarding the tox data from TiNivo-2. It looks pretty balanced between the two arms. It's a little challenging to, infer, because on the one hand, right, you've got, a lower dose of the TKI in combination with a checkpoint inhibitor versus, it's a full dose TKI. So, counterbalancing the two, understanding, attributions is always a little bit tricky in that context. I didn't see any really new or emerging safety signals. I think the data from TiNivo-2 sort of confirmed my clinical experience with the drug, which is that, perhaps the most challenging side effects, which I think are quite manageable with TiVo, tend to be the hypertension and fatigue. Those really do sort of stand out to me. I have, had instances where I've gotten cardiology involved, to manage refractory hypertension in my patients on TiVo. But, for the most part, it's something that I have been comfortable managing with in my clinic. And, and that's sometimes a stretch for me because I know very little cardiology.
Yeah, that's great to hear. And yes, I agree. We're fortunate to have cardio-oncology colleagues, but certainly learning a lot about hypertension and management there.